So, hello. Hi, everyone. I'm going to share with you today some of my experiences on case taking. These are some of the skills that I developed during my case taking process. So, I'll share my journey from the beginning, where I started as a student and I started to take cases, and how slowly I started discovering a more in-depth way or a more precise way of eliciting the peculiar characteristic symptoms in a particular case. So, for example, I started from my college days with this understanding that in every case, you need to form a complete symptom. So, complete symptom means having the location, sensation, and complaints, the modalities of the complaint, and the concomitant symptoms in that particular complaint. When you have these four aspects, along with the cause and the ODP, that is the onset, duration, progress, or the pace of the disease, then you have the cause, ODP, location, sensation, modality, concomitant, and in the end, I add mental symptoms. What are the mental symptoms associated with the particular complaint? So I start very simple. I used to only take one symptom at a time, even though the patient had 3 or 4 symptoms. I used to always start with just one symptom and try and form a complete symptom of that one particular symptom. Then take the second symptom, then third symptom, then fourth symptom. Right? So this is how I used to take a case. And I always felt that if you take a good complete symptom, you will find what is peculiar. Now what happened? Let me share some of my experiences with a case example. So for example, once a 25-30-year-old female came to me with the complaint of cough. She had a very bad cough. The cough was such that it began after she had some cold food. She drank cold water or she had ice cream. After this, she developed hoarseness of voice with a very dry cough, and the cough bout was such that it would make her feel breathless, or it would suffocate her. Along with the suffocation, there was palpitations in the heart, and breathlessness, suffocation, and she would have to then just sit and lie down. This cough was especially aggravated when she would have any kind of cold things, or she was exposed to any kind of cold weather, and she felt slightly better if she had warm drinks. So looking at these symptoms like cough, dry cough, aggravated by cold drinks, caused by cold drinks, I started thinking of dry cough remedies like spongia, and I gave her the remedy spongia, dry cough, spongia also has the suffocation with cough. So I felt spongia is good. She comes back after 2 to 3 days and she says that my cough in fact has gone worse. So now what to do? So I ask her again, what are your complaints? Can you describe? So she says the cough is the same every day morning when I get this cold air. I have aggravation. Then even in the daytime, if I go into cold air or I have something cold, I will have a cough. I'm better by warm drinks, the cough is dry, there is hoarseness, there is suffocation, everything seems to be the same. Now what do I do? And these were very initial days of my life. Because it was very initial days, I was very desperate that I have to make this patient better. No. So I was just thinking now, I have to find a peculiar symptom. I feel I have done a good job. There is a complete symptom. I know cause. I know it started around 2 to 3 hours around 24 hours after she had the ice cream. So the pace is also medium. The ODP I know it started with hoarseness, then the dryness of cough, and then the suffocation. I know the complaints. I know the location. I know the complaints, I know the modalities. There was no concomitant symptoms. I asked the patient mental symptoms. So she says, no mental symptoms, I can't tell. I'm okay mentally. Where to look now? Where to look? So at that time, I somehow come to this idea that this time she mentioned morning. Last time she did not mention anything about morning. She said morning I wake up and I have cough. I say, can you tell me what happens in the morning? Why do you get cough? So she says, I don't know why I get cough. I asked her, is it because of the cold air? You said it was because of the cold air. No, actually in the morning I'm in my house only. No, I just wake up and during the mornings I have cough. Okay, so I asked her, can you tell me at what time in the morning you have this cough? She says, no, I can't tell you the specific time. I said, okay, so what time do you wake up? So she says, I wake up around 6 o'clock, 6 a.m. Okay, at that time you have cough. So she says, no, I don't have. Okay, after that, when do you wake up? Or what do you do after waking up? So she says, um, after I wake up, I go to the washroom, I brush my teeth, have my bath, etc. So at that time you have cough. No, at that time I don't have cough. Okay. After that, what do you do? After that, I cook food. I have to get the breakfast ready for my husband, for my children. So I cook food. Okay. At that time, you have cough. She says, no, at that time, I don't have cough. Okay, what do you do next? Next is I go downstairs because I have to get water. For the drinking water, I have to go downstairs. So it's just one floor below, and I go there to get water. So I ask her, at that time you have cough. She says, yes, at that time I have cough. So initially I thought, okay, she's going outside, she's out in the open air, so maybe because of cold air she's getting the cough. But if you remember, I had already asked her, is it because of cold air? She says, no, it's not because of cold air in the morning. So some doubt, I still am, I think there has to be something else here. So I asked, what do you do in the when you are getting water? So she says, I get water and I have to get that vessel of water and I have to climb up the stairs. And actually, when I'm climbing up the stairs, no, it is at that moment that I have fun. And I climb up the stairs, and during that climbing up, I start feeling suffocated first. I'm getting breathless. When I'm getting breathless, then the cough begins, and then the suffocation increases, then the palpitation in the heart, etc. So I come home, I just sit for 2 minutes, then slowly my breathlessness reduces, the suffocation reduces, and then my cough also reduces. And actually, this happens during the daytime also. If I go out and I come back, when I'm coming back home, no, that time I have cough. Whenever I have to climb these stairs, I have cough. Then I understand that actually, more than the water or the cold air, the main modality in this case was cough aggravated ascending stairs. If you open Fatak's repertoire and see the rubric cough on ascending stairs, there is a single remedy in that rubric, that is urgentum nitrotum. Then you understand, urgentum nitrotum is a remedy for hoarseness of voice, urgentum nitrotum is a remedy for suffocation, urgentum nitrotum is a remedy for palpitations, fears, anxieties, etc. So everything then seems to fit in. I give her urgentum nitrotum and her cough completely disappears. And I get the whole family as my patient. So now, what this taught me basically was that even during trying to form a complete symptom, we have to have a very, very detective-like approach. You know, going into the minutest of detail of the patient's history. I actually went and lived the life of the patient during the morning to get out the peculiar symptom and started looking at the minutest of detail in her lifetime, which was causing the cough. And in that investigative approach, I find the peculiar. So, this taught me that it is not enough to just follow a structure. You have to have an attitude behind following that structure. And what I am going to tell you today is what is the attitude behind, what is the culture, or what is the intent with which you try to form a complete symptom. All of us know what is a complete symptom. All of us know that we have to take cause, we have to take onset, duration, progress, we have to take the first symptom, second symptom, third symptom, sequence of the uh, symptoms, then we have to take the modalities, then we have to take the concomitant, and we have to also observe the mental symptoms. But many times, even after doing this, we feel the peculiar is not very clearly standing out in front. That does not stand out because we are not having the real intensity behind. So I'm going to teach you the intensity today. What is the intent and how you can develop intent. So for that, the first quality was having a detective-like approach, which you saw in this case. The second quality that I observed is the use of examination skills. So let me explain you this with an example. The use of examination skills means this. That one patient came to me and her complaint was that she had a tumor in her breast. In her left breast, she had a tumor. This tumor was causing burning pain and redness in the breast area. Because it was bothering her, because of the redness, she got a little bit concerned and she went to the gynecologist. The gynecologist suggested that let's do a mammography, and in the mammography they found certain kind of activity. So we said, to be on the safer side, let's also do a biopsy. She does a biopsy. In the biopsy, they say that this tumor is borderline. We can't say that it is completely benign, but we cannot also say that it is malignant or it is cancer. It is in the in-between phase. So what we suggest is that you come back after 3 months and we will repeat a biopsy. So the patient gets concerned. She's worried. Oh my God, do I have cancer? Am I going to develop cancer? So she comes to us and she says, can homeopathy do something? My next biopsy report will be very, very clean and clear. I say, okay, you come, we can definitely do something. So she comes, she says that she has all these symptoms, redness and tenderness of near the nipple area where she can feel the tumor. I ask, what else? How did this start? Any cause? So she says, no, there's no cause. It just started on its own. Okay, can you tell me when did this start? How did this start? It started when I was around 2 months, 3 months. I don't remember exactly. It slowly began. What were the initial symptoms? The initial symptoms were like redness and pain and burning. That is gynecologist. The gynecologist suggested that let's do a mammography, and in the mammography they found certain kind of activity. So we said, to be on the safer side, let's also do a biopsy. She does a biopsy. In the biopsy, they say that this tumor is borderline. We can't say that it is completely benign, but we cannot also say that it is malignant or it is cancer. It is in the in-between phase. So what we suggest is that you come back after 3 months and we will repeat a biopsy. So the patient gets concerned. She's worried. Oh my God, do I have cancer? Am I going to develop cancer? So she comes to us and she says, can homeopathy do something? My next biopsy report will be very, very clean and clear. I say, okay, you come, we can definitely do something. So she comes, she says that she has all these symptoms, redness and tenderness of near the nipple area where she can feel the tumor. I ask, what else? How did this start? Any cause? So she says, no, there's no cause. It just started on its own. Okay, can you tell me when did this start? How did this start? It started when I was around 2 months, 3 months. I don't remember exactly. It slowly began. What were the initial symptoms? The initial symptoms were like redness and pain and burning. That is the same symptoms that I have even now. What else? When do you feel better? When is the pain worse? No, she says the pain is constant. It's always there. There's always this redness, burning, tenderness. Mm, no modality. Or any other complaint other than this you have? No, I don't have any other complaint. This is my only presenting. Okay. Any other? How are you feeling mentally, emotionally because of this tumor? No, I'm okay mentally. I'm a little bit worried because of the report. The report is not so good. So I'm anxious. What will come up? Any other thing you feel? No other thing. So you see, I am saying that it is a dead end again. I don't know where to take it forward from here. She talks about anxiety, but I felt the anxiety was relevant to the situation that she was in. Now again, what to do? So I started to think, what can I ask this patient? In this patient, there was no morning also, there was no good evening also to probe the history or to go into something, that I can really probe it. No modality also. Where to go now? No cause. Where to go? Only thing I had was the pain and tenderness in the breast. Nothing else I had. So I said, whatever I do now, I have to find a way to go deeper into this particular window. There is no other window available to me. The only window available now is the pain and tenderness. So I thought, if I have to do only that much, if that's my only option, why not just examine? So I examine. I see there is tenderness. I see there is redness. I see there is heat. Common symptom. What to do? No? So then I remembered in examination we used to be always taught to see the very what you say precise features like how much is the size of the tumor, whether the tumor is soft to touch, whether it is hard to touch, whether it is um, uh, what you say red inflamed or not red inflamed, whether it is painless or painful, etc. And once you do all these examinations, then you see the um, other associated areas which can be affected along with the local examination. So I did local examination, same symptoms came up. Then I think of the associated features. In the associated things, especially related to breast, what you examine is you examine the axilla and you actually look for lymph nodes there or something in the axilla. So I started thinking, hmm, let me ask some questions about axilla. So I say, along with this tenderness, do you have anything that you feel in your axilla? So she says, no, nothing in the axilla. Any nodes you feel, any? No, she says, no, nothing is there. Then I ask, okay, there's nothing. So I think, okay, what else I can ask about axilla? What are the other symptoms that can be produced in the axilla? So I say in the axilla there is hair. I ask any hair problem you have there? No. Okay. Um, okay, sweat. Generally we see sweating in axilla. How is sweating? So she says, there is lot of sweating in my axilla. There is lots of sweating. I say, what is this sweating? She says, lots of sweating. I'm telling you, I have so much sweat there. I said, so can you tell me about this? Yeah, doctor, whenever it is summer, no, in summer weather, I can't tolerate sun. And if there is sun, then I sweat a lot. And I sweat not only in my axilla, I sweat everywhere. The whole body I sweat. And this sweat was so uh, bad, is so bad that it is firstly, very offensive. I have a very offensive smell, and it is very profuse. And then I have, itching on my skin. Then with the itching, there is redness on the skin. So there was redness all over, the whole chest area, the back area I used to get because of my itching, perspiration, sweating. And in the sun, I also developed very bad headaches, very severe headaches. I just can't tolerate summers. During summers, I will have this sweating, I will have headaches, and I will have burning urination. So during summers, I just want to sit home. I don't want to go anywhere. Then I I asked about the sweat, and she gave me a whole lot of symptoms. And these symptoms were not just local, they were general symptoms. No, the perspiration was not limited only to the axilla, it was all over the body. She also gave me modalities, which is aggravated by summer, which is aggravated by which aggravate the summer aggravates the urination, the summer aggravates her sweating, the summer aggravates her headache. So there were so many different localities being affected along with the sweat, along with the heat, along with the burning. And you can see the same heat and burning and redness in the breast presently. The same heat and burning and redness was there during the summer also. So this is the most general symptom in this patient. Summer aggravation, heat aggravation causing burning, heat, inflammation, offensive sweat, burning urination, etc. Are you with me?
I am.
Huh? You're understanding, right? Now what happens is, I say, so what happened to this sweat? What do you do at that time? So she says, doctor, I must tell you, the sweat has stopped. This summer I didn't have the sweat. I said, why? I took treatments. I put lot of talcum powder. I took many treatments to suppress this sweat. I just wanted this sweat to completely stop. And this year, I thought, wow, I got rid of my sweat problem, and now this breast problem is. And I'm thinking, I get rid of one problem, I'll end up in another problem. So I understand that is why I couldn't get a lot of symptoms in the breast, because the breast was only a manifestation of the suppressed discharges or the suppressed sweat. So that's why another symptom I get. Suppressed sweat, suppressed perspiration, causing to heat, burning, inflammation, redness. So I think by now you must know the remedy that I gave her. The remedy that I gave her was sulfur. Offensive sweat, suppressed discharges, redness, heat, inflammation, burning, everything. Burning urination. So I give her sulfur. And with sulfur, she completely improves. She says, doctor, I didn't tell you about my headaches, but my headache improved. Arey, I didn't mention about acidity. I had a lot of acidity. That is also gone. My breast tenderness is completely gone. I have started sweating again. But now what happens is the sweat is not offensive and it's not so bothering for me. I can tolerate my sweat. In fact, I am surprised I am able to tolerate heat nowadays. I am going out in the sun. I never would have been able to in the past. I am going out in the sun and I am still able to manage. I still am bothered by it, but it's not so bothering that I just stop going outside. I am able to do that. And the report after 3 months was normal. The biopsy report came back normal and she was very happy. So, the learning from this case is that when you see that there is only one window and you don't know how to enter that window, it is always a good idea to open some kind of clinical book and see what are the various symptoms that can be asked in examination of that local complaint. You can open Google also. Nowadays there's Google, nowadays there's so much information available. You can just type what are the various symptoms to be examined in examination of a tumor or in examination of stomach, and then you just keep asking patient, the patient, do you have this symptom? Do you have this symptom? Do you have this symptom? And from those symptoms, suddenly something will open up and the whole case will get generalized, like you saw in this case. So this is another very, very important quality, the use of clinical skills. Right?
Okay, yeah.
Second quality. If there are any doubts, you can ask in between.
Okay.
So up till now, clear?
Clear.
Detective-like approach and use of examination skills. Next thing is, I will like to give you the learning after I share the case. So once one young girl around 10 years, 10 to 12 years came to me and she said, doctor, I have hearing loss. I have difficulty in hearing. So I asked her, tell me about hearing. What is it about hearing? No, I can't hear. That's the only thing. So what you can't hear? No, I can't hear noises. I said, no, tell me what exactly happens. When you can't hear? She says, whenever there is noise, I can't hear. I say, what kind of noise? No, if it is a very loud noise, no, then I can't hear. I say, why? What is the problem? No, if sometimes even from small, minor noises also I am not able to hear. I say, what happens if you get a loud noise or sometimes even from a normal noise? What happens? Doctor, what happens is I am not able to actually understand what's happening around. I feel like, everything is spinning. Everything is spinning. I think I have vertigo actually from the noise. And many times while I am lying down also, I feel like, it's giddy. Then I sometimes sit up, then I hold my head, and then I say, okay, now the giddiness is reducing, or the vertigo is reducing. So this is very strange in this patient. She came to me with the presenting symptom of hearing loss. I am asking her to describe hearing loss, and she does not talk anything about not being able to hear. She does not say, I am not able to hear low voices, I am not able to hear loud voices. What she is meaning I am not able to tolerate noise. Are you getting it? She is not saying I am not able to hear. If she is not able to hear, that should not even affect her.
Right.
She is saying that I am not able to tolerate noise. And this noise causes vertigo. So in this patient, even though her presenting symptom was hearing loss, you don't look at hearing loss. You look at intolerance of noise causing vertigo. That is the symptom in this case. Right? Now you may feel, you have observed very acutely that it was not hearing loss, it was intolerance to noise. Correct?
Correct.
But this acuteness to me has come Because I followed the last learning that I taught you. The last learning I taught you is asking the various symptoms related to hearing loss. So that was there in the back of my mind. I have to ask symptoms related to hearing loss, and this patient has to tell me that I am not able to hear this kind of noise, I am not able to hear that kind of noise, right?
Mm-hmm.
Or she has to give me symptoms, other symptoms of ear like tinnitus, or she has to give me a history of something going wrong with the what you say ear. Maybe she had an infection, some kind of ear symptoms she should have given me. Strangely, she is not giving me ear symptom. She is not talking about hearing loss. She is talking about something different. So my attention goes. She's not talking about what I want her to talk. According to examination, she should tell that I am not able to hear this kind of noise. She's talking something different. That's why I become attentive. I say, listen carefully. There is something here. She's not talking what is expected. So then, when I become alert, I realize, she's not talking about hearing loss. She's talking about intolerance to noise. You get me? So you follow these instructions, the acuteness, the alertness, the sound senses that Hahnemann taught us will come to you. It will develop within you. These qualities that Hahnemann has told us, that we have to be open, that we have to have acute senses, there should be fidelity in tracing the picture of the disease, are qualities that are to be developed, and that will come to you if you follow strict guidelines, protocols with intensity. These qualities happen to me. I am sharing you how these qualities came to me, how these developed within me. I was very simple. I was just doing what I learned, but I was doing it with utmost sincerity, dedication, and passion, and not accepting things. This is all I will get. I have to work with only this much. That attitude I never had. That attitude was given to me by my teachers. That never accept, this is it. No. The ultimate truth in homeopathy is only one. Find the peculiar characteristic symptom. For that, whatever is needed, and you have to do whatever you have to. Right?
Right.
Clear until now?
Very clear.
Okay. So this now from here what you see is the quality of being very alert, vigilant. This is the quality that I wanted you to see here. The quality of being very alert, vigilant, having sound senses, seeing everything seems normal. You know, patients say like nothing has happened. This is just normal. If you have acute senses, you'll see this is not normal. This is abnormal. So similarly, one more case I want to tell you regarding the acuteness and alertness. That quality is the quality of seeing the exact location also during examination. So once one patient came to me and she said, "Doctor, I have skin problem. I have eczema." I said, "Okay. So where is your eczema?" She said, "Well, it is here on my forehead, then it is on my forearms here, then it is on my legs, on my leg." So I said, "Okay, what other symptoms, etc." But because my focus is on a location, I'm not going to tell you the rest of the case. The rest of the case is okay, she has itching and the eczema is dry, etc. Now, I say, here again, I was not getting more symptoms, so I again started to rely on examination. So I said, where can I see the eruption? So first thought that came to my mind was, okay, can I see eruptions on forehead? Or can I see eruptions on forearms? Or can I see eruptions on legs? I said, okay, let us do that. Now, what happened? She said, then she, when I was examining her, she suddenly said, see, doctor, here, wherever there is um, prominence, on my forehead, that is the area that I have my eczema. You know, here, here, on my eyebrows, here also you see, here it is, here. Then it struck me. I knew one remedy which has this. The remedy was eruptions on bony surfaces. Okay. So here you see there is the bone and directly skin. In the forearm, she didn't have here on the flexor aspect where there is muscle. The eruption was on the bony surface where you can feel your here radius. You can feel your radius bone over here. On that part only she had eczema. On the legs, the eczema was only on the tibial surface, where you can feel the tibia, where there is no muscle, where there is no fat there. Then I understood that her eczema is on bony surfaces. It's not face or forearms or legs. Right. So then this case taught me that be more exact, more particular, more acute. Seeing the location also. And I can give you many such examples. But I think the idea is to give you the idea of how important these factors are. Right?
Right, yeah.
So, these were the 3-4 aspects regarding use of examination skills. And with that skills, you will see that you will develop these qualities of acuteness of senses, alertness, vigilance, and more preciseness in your observation. So that is what these two cases were about: being precise, exact, accurate, alert.
Yes.
So, first was detective-like skill. Second was using of clinical skills or examination skills, which will later on develop your acuteness. Now let me introduce you to another skill, that is the skill of attentive listening, because now you know attentive listening, right? What it is. So that is the third quality. So what is attentive listening? One patient comes to me and she says, "Doctor, I have migraine attacks." I said, "Okay, talk about your migraine." So she says, "Every day morning when I wake up, I have this headaches." So I hear morning and I remember argentum nitricum. I say morning. History, geography of morning. So I say now, any other modality are you giving me or no? Any other cause, location? So I try first do the complete symptom. You don't, I will enter morning and I go with lot of enthusiasm and I say I will examine this morning and I'll get the picture. So I go there and I ask her, "So can you tell me what happens in the morning? When do you wake up?" "I wake up at this time." "Then what happens?" "Then this happens." "Then when do you have?" He says, "No." And I end up, a little bit discouraged. In this case, the morning is not working. what to do. I thought detective like skill, I will examine, I will go into the life of the patient and I will get the symptom. She has told me very clearly that morning when I wake up, I have headaches. So I said, okay, detective like skill didn't work. So let me use the examination skill. What can I examine about morning or about waking up or about headache? So I asked location of headache, I asked extension of headache. What can I examine? Nothing to examine. No, in the head, what do you examine? I read Google, any other thing that we can examine regarding headaches. Nothing comes up. All they give is there can be systemic causes, there can be this cause, there can be that cause. So you can. So basically, they what they give other than the local examination is the concomitants. Whether it is because of neurological cause, whether it is because of the heart, whether it is because of the food or acidity, you can examine those associated factors. I ask patient, you have acidity problem, you have heart problem, any other concomitant? No. So here you see examination also does not take me ahead. What to do? Then I said, from the examination protocol, what I learned was being very alert, right? So I said, today I don't have examination, but why can't I just be alert, just as a policy? So I tell this patient, please tell me your symptoms again, we have not met for the last 15-20 minutes, but just start again and tell me about what to do. I start observing very carefully what will she say. Being very attentive here. So then I hear that she says, doctor, I am telling you, every day morning when I wake up, I have headache. So I say she's focusing on waking up. So I ask her, waking up, can we talk about waking up? Just vaguely I ask, I don't know what to ask. What can I ask about waking up? So waking up, like a question mark sign on my face. Waking up? Yeah, yes, waking up. That is my problem. So what in the waking up? No, I don't know about what. But, when I wake up, I have. Maybe it is to do with sleep. No? So I ask her, anything to do with sleep? So she says, yes. Doctor, I am telling you, every day, my sleep is not good. I sleep well, but I get up unrefreshed. My sleep is not deep enough. The sleep is very unrefreshing. So, and I get a lot of dreams in my sleep. Maybe because of that, my sleep is a problem. So, in this case, it went the other way. In this case, you can see that things opened up from the sleep. No, now I have dreams that I can ask. Now I have the symptom that lack of sleep is causing the headache, right? She's not getting deep enough sleep. I have these symptoms now. But I don't want to focus on the case as such. I want to focus on what happened and what led to these symptoms to come out. As I told you, the thing that I was using was becoming alert. No, it was very acute in observing. And what I observed in the acuteness is, where is the intensity in this sentence? That cough is, the headache is aggravated when I wake up. So, to give you an example, like, if you take the sentence that today in Mumbai, local trains are late. Okay, so one person can say that today in Mumbai, local trains are late. So for him, what is important is Mumbai. Today in Mumbai, local trains are late. So for him, what is important is local trains. Today in Mumbai, local trains are late. For him, today is important. So, three different persons talking the same sentence, but every person's problem is different. Are you getting it?
Yeah, it's good. Yeah.
This is the same. The words are the same, but the intensity in a particular word is different in different people.
Right.
This I observed here, that in her, the intensity was not in the morning. It was my prejudice that in some case, morning work, so I kept drilling morning. So what happens when you wake up? When you wake up in the morning, you have headache. So it is because of waking up. Okay, it is because of the bed position. It is because of opening eyes. What? And nothing came up there. When I took a backtrack and I focused on where the intensity is, I see the intensity is in waking up. That is alertness. That is, really listening, very attentive, very carefully. It is waking up here. So, first what I do is I just throw a general question, waking up. No, nothing. I don't know also what to ask. I just say, waking up, and I make an expression, waking up. So you see, something happens. Then she talks about sleep, then she talks about dreams. So that is what happens. In a case, if you touch the sensitive point, no, you have to only touch it. You don't lead it then. Can you talk about waking up? Can you talk about sleep? You don't need to even do that. You just touch that sensitivity and things just come out. Like in the sulfur case. See, I only touched the perspiration and the whole symptomatology just came out spontaneously. Yes?
Yeah.
Here, you see, I touch sleep, I touch waking up, everything just comes up spontaneously. And for 15-20 minutes, I am struggling. What to ask, where to ask, how to ask. This is the next quality that I wanted to highlight. The quality of being very, very vigilant, alert. I call it attentive listening. The quality of being vigilant. Got it? That's the third quality.
Okay.
So one more quality is the quality of making the patient live in that moment. So you saw that in the urgentum case, I actually lived the life of the patient with the patient in the morning, right? And that quality you should develop in eliciting every symptom or every modality. So, for example, one case that I can narrate about this is one patient, she comes to me and she says that I have menstrual colic, menstrual cramps, and very severe menstrual cramps. And when I have this menstrual cramps, I cannot do anything. I cannot sit, I cannot walk, and I just lie down, and that's the only position that I can be in. Hmm? So many times what happens is we take this symptom, menstrual cramps ameliorated by lying down. Oh, that's the only position that I lie down. That's what the patient has said. Now, the problem here is, first, the patient has not said that I am better by lying down. She has said that is the only position that I can take. So what it means is menstrual cramps compels her to lie down. Compelled to lie down. That's all it means. The patient has not said I am better by lying down. Right?
Right.
So then what you do is you then ask the patient, how do you lie down? In what position do you lie down? So, doctor, I lie down on the right side. How do you lie down on the right side? I lie down with my, legs on my stomach. Okay, then you see. Or I lie down with my legs stretched straight. So one patient, she tells me, this patient only, she tells me that actually I lie down on my back only. I don't lie down on the right side or I don't lie down on the left side. I always lie on my back. I say, why on the back? No, that's the only position that I lie down. Okay, how are your hands? How are your legs? She says, my hands and legs are always straight. I say, why straight? So she says, in fact, they are not just straight. In fact, if these are my feet, I extend my feet and I, try to pull them, extend them more. If I extend them, no, then, my pain reduces a bit. Then I am at least able to tolerate my pain. So then I understand in this case, the modality is stretching, extending, right? Extending the feet. It is not anything to do with lying down. It is to do with extending. That is what is important. Whatever you get, it is always better to throw one thing completely, exactly, with preciseness, accuracy, alertness, rather than trying to do 10 different areas of the patient and reaching nowhere and confusing ourselves with so much of data. My suggestion is always focus on 1, 2, or 3 symptoms. Just do with intensity only 1 or 2. You will find peculiar. From there only everything will automatically get generalized. There only you will see the peculiar, you will see the general. There is a saying, no? Whether it is the ocean or the drop of the ocean, it is the same. So just focus on the drop of the ocean. If you understand that drop, it is enough. You will understand the ocean. You will go and try to understand the ocean, you will be at sea, you will be lost. Focus on the drop. The sea will come and tell you what it is. Things come and tell you. All these arts that are written in the books, about alertness, seeing the general, seeing the essence, seeing the spirit, are something that come and happen to you. They are not something that you have to go and search. It will come and happen to you. And it will be like realization. Today I saw it. Let that happen. Don't try to make it happen. That's the whole difference. The whole mistake we do is we try to make it happen. We try to see the connection. We try to use our mind. Stop. Let the patient do it for you. Nobody knows better than the patient. He will do it for you. He will tell. This happened here also, this happened here also, this happened there also. Just focus on the minutest of detail. Just live the life with the patient. Live it with him. Wait for that one entry point. The moment you get that entry point, then bring in this detective-like skill, the examination skill, the attentive listening, or living in the moment. You see things will start happening. Right? So I think for today we'll do one more last quality. And the last quality is, it's an artistic one. It comes to you after years of practice and putting in all these protocols that I taught you to do. You put them into practice, and then you slowly develop having these qualities after years of practice. Okay? So, one patient comes to me and he says that, doctor, I have 3 or 4 complaints. But let's start with my main complaint or the most bothering. The most bothering complaint that I have is I have breathlessness. I have dyspnea. So I say, okay, so please talk about your breathlessness or your dyspnea. So he says, my breathlessness is such, doctor, that I am not able to sit in one position. I can't sit. If I am at the farm, if I am working, I have no breathlessness. If I come home, if I sit down, if I have to eat something, I have breathlessness. When I am at the farm, I am busy in the work and I don't even recognize that I am having the breathlessness. I come home, I have the breathlessness. I don't know what it is. And I feel very restless at home. I can't sit at home. I feel that I want to go to the farm. But in the evening, I have to come home. No, in the evening or at the night, what work is there in the farm? So I have to come home. When I come home, in the evening, I have coffee. Now, in this case, what is interesting is you already have a lot of peculiar symptoms. No? Breathlessness, better or aggravated when sitting, is strange. Generally, you will see during exertion I get breathless. During exertion I feel dyspnea, right? It is strange. He's saying, I'm sitting and I'm getting breathless. Strange. Then you can also see symptoms like you can say, this patient is maybe ameliorated when he is busy. Or you can say, maybe this patient is aggravated during rest. Right?
Mm-hmm.
So there is busy, there is rest, there is from sitting down. So what to take? Everything seems relevant.
Mm-hmm.
And depending upon our knowledge, like my morning knowledge we will take. If we have knowledge of some busy remedies, we will take busy. If we have knowledge of some remedies which are ameliorated when busy, we take those, or aggravated when rest, we take those. Or someone will say, this is very peculiar. I can't leave this symptom. That, I have, when sitting, I am breathless. So what is important in homeopathy? Even when you see 3, 4 particular symptoms or peculiar symptoms, is that you have to know how to see the essence or the spirit in these symptoms.
Mm-hmm.
You have to see what is it that is connecting all these.
Mm-hmm.
Then again, you have to be very, very observant. So in this case, what I did is I started observing the patient and I am getting confused whether it is busy, whether it is rest, or whether it is dyspnea aggravated sitting down. Or he also said restlessness. So I'm restless in the evening. So should I take a restlessness? So I said, just relax, don't lead anywhere. And just relax and keep listening to the patient and observing the patient. Then I see that he has restless feet. His feet are always like this. So completely out of the blue. I say, okay, this symptom is okay. Why are you moving your legs so much? So he says, no, that's my problem. No, that is what I'm telling you. I said, what are you telling me? That I am very restless. Because I am so restless. No, I can't sit at home. Because I'm so restless, I have to be always at the farm. Because I'm so restless, I'm thinking, when will you finish this interview? When will this get over? I can't sit here for 1 hour, 1.5 hours. I know the patient that referred me to you said the first interview will be at least for 1 hour. In fact, for that only I was thinking whether I should come. I can't sit for 1.5 hours. So, I want to get, I'm getting restless. I can't sit for so long. So you see, his main symptom is restlessness.
Mm-hmm.
Because of restlessness, he can't sit in the interview. Because of his restlessness, he has to always be moving around in the farm. Because of his restlessness, he can't sit at home. Because of his restlessness, he is feeling breathless. Right?
Mm-hmm.
So the main symptom in this case is restlessness, and all the other symptoms that we discussed are not relevant in this case.
Right.
Because that's not the spirit, that's not the essence. This is the most refined or the most artistic part of case study, to see the essence behind, the spirit behind the words the patient is using. Not only listening to the words of the patient, but looking behind the words, what these words mean. What does this constellation of words tell me? This is the work of all the great stalwarts of homeopathy, whether it is Vittelgaard, whether it is Shankaran, whether it is anybody. That is what they are trying to teach you, to look beyond the words, to look at the spirit of what the patient is trying to tell you, to look at the essence or the sensation or the energy. This is what it is. This is the energy of the patient. This is the spirit of the patient with which he's talking.
Mm-hmm.
This is what is the sensation level. This is what is generalization according to Kent. This is what is grand generalization of Boning saying. You see that one particular pattern in various symptoms of the patient. That is generalization. To put it in simpler words, you can call it generalization of Boning Hussein or Kent, or you can give different words to the same expression. But this is what it is.
Mm-hmm.
Right?
Mm-hmm.
So, before you develop this skill of generalization, seeing at the spirit or essence, you should focus on the previous qualities that I taught you today. Stay there. These things will come and happen to you. Don't get overwhelmed by, oh my god, I have to see the spirit. That is what homeopathy is. That is what essence is. These qualities are developed after years of practice. So I wish you best of luck to follow the first 3-4 qualities, and with luck, with grace, with God's grace, you will someday start to see the spirit or the essence. But till then, focus on what you understand.
Mm-hmm.
Right?
Mm-hmm.
If that helps you all. Thank you.